Hello, and welcome to another of our Conversations with Pathologists. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center, and my guest today is Dr. Michael Dugan, who's Vice President at Biosept. Now, Michael and I have known each other for a number of years, but we first came in contact at, I think, a meeting many years ago, and over digital pathology, I think, at the time. But Michael has made a real variety of things his venue as he's moved through his career, and thus I think has a very unique perspective on what the life as a pathologist can be like and where it can lead you. So Michael, why don't you give us just a little bit of a background, sort of a blow by blow of how you started into pathology and then how that path has wandered forward.
Well, thank you, Lewis. I've had probably the most roundabout career as a pathologist one could hope for, but it started as a medical student when I was looking for something to do that was a little bit out of the ordinary from my routine medical courses. And I had a mentor who suggested I work with a pathologist named Dr. Tom Grogan, who was a young pathologist at the time at the University of Arizona, looking at immunohistochemistry stains to try to classify lymphomas. And it was an interesting foray into that field. And I actually worked on rat spleens rather than lymphomas, but I looked at the anatomy of the spleen and studied its development in response to pneumococcal antigen, and found that the anatomy was closely related to the blood vasculature supply to the spleen, and that corresponded to what they had seen experimentally with rats that had a pneumococcal challenge, and it led to developing some expertise in that field. And he encouraged me to do more pathology, and I did a year of research overseas in Australia, looking at more of the development of the immune system, and eventually came back to Tucson and finished up my 4 years there, and became a pathologist. And he was very instrumental in helping guide me into a pathology career and help me select where I would go.
And certainly for our listeners who don't know and recognize Tom Grogan, the advent of Ventana as one of the leading manufacturers and makers of immunohistochemistry instruments and reagents is intimately associated with his career and his expertise coming out of Tucson there. So certainly had you put $1 in his pocket and stuck with him, that would have launched you and fixed you very well for a long time to come.
It was a funny story because, we were doing everything manually, including, using upside down cafeteria trays to create humidity chambers with wet paper towels under the slides and hand pipettes to pipette the reagents onto the slides. And he said, there's got to be a better way to do this. So he invented a company that eventually was worldwide famous for the Ventana benchmark platform. And it was sold to Roche about 2009 or something for something like $3 billion, which I think was the biggest deal ever in biotech history at the time, and the biggest deal in Arizona history ever.
Yeah. Well, and then once you started into pathology training, you also crossed paths with a number of really muckety-muck famous names and so forth. Tell us a little bit about that.
Yeah, well, Tom Grogan said, don't stay here. You already know everybody here in Tucson. We're a relatively small program. You should go somewhere else and learn pathology. So he encouraged me to cruise around the East Coast or the West Coast and find a place to, pursue pathology. He didn't recommend Oklahoma, but he probably should have. You've grown a lot since then. And I didn't look at any places in Texas, or I think I interviewed one or two places in Chicago, but mostly on the East Coast. And I was from Arizona. And I remember specifically he said, you should look at Dr. Juan Rosai at Yale because he's a very famous pathologist. And it ended up, I got an interview there, I think set up on like a Wednesday or something. And Dr. Rosai was busy that day, and his assistant called as I'm already on the East Coast traveling through a bunch of programs. And she said, she called my house and got a hold of my mom and said, could Mike Dugan stop by Tuesday night instead of Wednesday for the interview with Dr. Rosai? And my mother said, well, I don't know, I'll try to reach him. And I ended up getting a phone call from her saying, you've got to get on that train down from Boston to New Haven and see him on Tuesday night. I didn't know he's the most famous pathologist in the world. But I get to the hospital and call from the, we didn't have cell phones back then, so the train was late. I called from the lobby and got a hold of him and said, is it okay to meet you? And it's like 10 o'clock at night. He says, oh yeah, I'll be right down. He picks me up and comes down to the lobby, picks me up, takes me back to his office. I said, do you always stay here this late? And he said, usually I'm here until midnight. And he was writing this book right here behind me, this 2-volume book. And that was like the 5th or 6th edition, and he went on, or 7th edition. He went on to do 10 editions of that book, and he was, a master of pathology and very well renowned around the world. And I was one of just 6 residents accepted that year, a great privilege, and worked with some great pathologists like David Klimstra, who's now the chair of pathology at Memorial Sloan Kettering, and Giovanni Tellini, who was another Italian, and others.
Yeah, so I can appreciate your story about Dr. Osai, because I also had a near miss when I was interviewing, looking at programs, and included his program on my list. But at the time, he was in Minnesota, which was a much less hospitable climate. And little did I know that had I even gone there, he would have been out the door on his way to Yale before I could have, matriculated. So, I didn't follow him in that direction, but I know the allure of learning with a great teacher and learning with someone who really cares about the trainees, which is so valuable and not hard to find in pathology, whether they're famous or less notorious and so forth.
Mm-hmm.
So from there, what came next and why?
Well, I'd had a long interest in from college, and there was a guy. I went to the University of Notre Dame, and there was a guy there, Harvey Bender, who was a biology professor that got me interested in genetics, and another professor who got me interested in embryology. I can't remember his name actually, and but Bender was sufficiently interesting that I said, "Can we do some more work together, like reading about genetics and so forth?" So he and I did a special course in college where I read the history of genetics according to Harvey Bender, which was like all these classic texts on some of the famous geneticists. And when I got into pathology, I was thinking, how do I apply this sort of stuff to pathology, to embryology and genetics? And I set upon the idea, maybe I should become a pediatric pathologist. And so I went to a pediatric pathologist. Of course, Rosia had taught me a lot about rare tumors, and nothing's hardly more rare than pediatric tumors. So I'd gone to a symposium down at the NIH to listen to something about pediatric tumors, to learn something about it. And I met a guy named Timothy Trish, who was one of the first pathologists using fluorescence fluorescence in situ hybridization probes, or FISH probes, to look at genes that were altered in tumors of children, namely things like neuroblastoma or retinoblastoma, or other things where they had alterations of these probes. And this was really novel stuff for the time. There was nothing like it of the era. And so I said, well, this Tim Trish is a pretty interesting guy. I should go study with him. And it turns out he was going to go to Los Angeles and be the chair of pathology there very shortly. And I applied to the program as a pediatric pathology fellow and got accepted and went to Los Angeles, which was great for me because my family was in Arizona. It was a lot closer than the East Coast, and set upon studying that. And there I met all these other interesting pathologists that were, like Ben Landing, the father of pediatric pathology, and Hart Isaac, who had written this textbook of tumors that occurred in infancy or childbirth, at childbirth. And I just couldn't believe these. And then Floyd Gillis, who was a very famous pathologist, neuropathologist, who looked at pediatric brain tumors. And I just couldn't imagine that such a concentration of expertise could be in that one building. There was also a person named Hiro Shimada, who was a Japanese pathologist who wrote the seminal papers on the presence of these findings in these neuroblastomas, and he really established the classification system for them. So it was really interesting times and great to study with him.
So you did some general practice of pathology after your fellowship as well, in some clinical settings, and a hospital-based role, kind of a more conventional pathology role, did you not?
Well, at the time, I was really set upon, I got offered positions in community practice as a pediatric pathologist in Orange County, and I decided not to take it. I wanted to do I felt like a pediatric hospital would probably need people who knew a little bit about the laboratory side too. So I applied to USC and UCLA for a continuation of my career or training in lab medicine, because the board wouldn't let me do that at Children's Hospital because it was a small program without a 4-year program. So I went to UCLA and I started studying clinical pathology, which was very interesting there. People like Wayne Grody in molecular pathology, one of the pioneers, a number of people. Peter Hawanitz was a very famous, he wrote a textbook on laboratory medicine. He was there, and a number of very famous anatomic pathologists too. So I got a chance to work with both. Did that for a couple of years, was pretty much set then. I wanted to do an academic career, but there was no position at UCLA. So I went all the way to Wayne State University in Detroit, where I got my first position as an academic pathologist in a busy hospital in downtown Detroit, Detroit Medical Center at Wayne State University. And it was no time at all. I was doing adult surg path, pediatric surg path, adult heme path, pediatric heme path, and trying to run a clinical research program in, of all things, pancreatic cancer, because they needed a pancreatic pathologist. And I arrived there not knowing anything about pancreas, but the Chairman John Christman said, "You're it, Mike."
And when you're an adaptable recent trainee, you can do those sorts of, heroic tasks, amazingly. So
You do, and it was fun. I learned a lot more. I worked with another molecular a researcher who was very helpful, Fazlul Sarkar, and together we did a lot of papers on the molecular aspects of pancreas cancer, which really set my career into molecular pathology. In fact, we were publishing papers at the time that were later quoted as some of the most important papers in the history of pancreas cancer for the 1990s. Now, at the time, it seemed really crude by today's comparisons, but they were highlighting some things like certain molecular alterations that were predisposing to bad or good treatment responses with radiation or chemotherapy. Now, those are very crude predecessors to today's companion diagnostics, but things like P53 or KRAS mutations could actually predict which patients would do poorly or better with treatment, and that had never been published before, and it just was really, really out there at the time, and it was probably not very well recognized because I was not famous at all. I was a really obscure pathologist from Detroit, Michigan.
Well, and so where's the bridge from that sort of academic and research side, as well as a lot of clinical work, towards, maybe the more commercial side, if you will, or the biotech industry? I mean, you've obviously laid a lot of the foundation with your, work with various developing technologies, but where did you cross the bridge, say, from more clinical patient care oriented and research oriented to, device development, drug development, biotech kind of things?
Well, here's where it gets convoluted, Louis. I think the everybody in their life faces career choices that are partly familial, partly what you want to do, and partly what's possible. And at the time, I had a young family, brand new daughter, and I wanted to be closer to my family. And I had an opportunity to move out to, actually I had visited California to visit family, and called a pathology group there and said, would you happen to have a pathology job in Los Angeles? I really want to move back to Los Angeles from Detroit after being there about 3 years. And I would have been interested in pursuing my academic career further, but there just were limited opportunities. And this large group, it actually is Eric Glassy and Al Louis' group in Torrance, California. They had a need for pathologists, and they serviced a lot of hospitals in Southern LA County and Orange County. And so I joined them, and I worked with them for several years and really did a lot of work. In fact, I got asked to help out at Harbor UCLA with another academic program, helping them in the heme path side due to my experience with that. And that was very helpful, and I got to be back in a teaching role, and it eventually led to an invitation to go to UCLA at a sister hospital or a branch hospital they had purchased in Santa Monica, and I became the head of pathology. And there I did a lot of general community pathology practice, but in the context of an academic group. And it was out of the blue one day about 2 years later that one of the commercial reference laboratories that had been started in Santa Monica by a former UCLA rheumatologist, it was called Specialty Laboratories. They called me one day because they had lost their medical director, And in fact, they'd gone through the ringer with a regulatory agency here in California over licensure of med techs. And due to that problem, they had, the medical director had to step down, and a variety of other people they had some changeover. And so the company was in great flux, and they needed somebody right away. And the CEO, who had just stepped in basically just new on the job as CEO a few months, he had taken on both roles because he was an MD and a pathologist, and Doug Harrington. And he and I had met a few years before, and he said, Mike, do you want to do this job? We were actually introduced to somebody that I knew from UCLA days, years before when I was a resident. And I had helped out specialty as a resident, ironically, part-time when they were really a tiny little company. I'd helped out when I was a resident reading flow cytometry and breast immunohistochemistry for ER/PR and HER2/neu markers. I had done that just as like moonlighting when I was a resident to make a little bit of extra money. Well, in the interim, like 6 or 7 years, they had really grown on the heels of the introduction of PCR testing for detection of things like HIV virus during the early years of the HIV epidemic. And so they went public on the New York Stock Exchange on the heels of tests like HIV viral load for looking at patients who had were being treated for HIV and might respond or not respond. And they had other tests for like H. pylori and so forth, very novel tests. And so they had gone public on the New York Stock Exchange, grown really rapidly, and then they got into this issue with licensure with the state, and the state almost shut them down because they didn't have licensure appropriate for every single position that they had, and they had a big debate over what was required and the state rules versus other states and all this other stuff, and it was real nasty. But the company was very novel, had a lot of interesting products, and I got into the door and tried to help steer them clear of any more regulatory issues. And we helped build the company back until it was really it was one of the leading companies in developing novel tests that would be sold through hospitals as a reference lab. So hospitals would collect, or physicians that were at a local place would send their samples through the hospital and then send it on to specialty laboratories, much like ARUP or Mayo Clinic today. And they were our chief competitors at the time. Before the California regulatory incident, I think specialty was the leading provider of some of these tests, and then we had to kind of recover ground lost during that year, and I helped rebuild them. And eventually our company was purchased by a company called Ameripath. That was a big roll-up of many different pathology groups across the country, and Ameripath had several smaller labs, and we became their hub lab. And then the combined entity that Ameripath and specialty had was sold off to Quest about 2007, I believe. And at that time, I could have stayed at Quest, but when companies go through rollovers like that, recruiters start to call thinking that maybe the executive team might be looking at other jobs. And that's what happened to me.
Okay. So you sort of just stumbled into the transition to then a sort of a commercial laboratory situation. And then from there, it was maybe an easier step onto other venues and so forth.
I would say volunteering in something outside of your normal practice, like volunteering with specialty when I was a resident, helped me make the transition, because I thought, well, I'm somewhat familiar with what the lab looks like. I didn't realize how much it had grown and how complex it had become. Yeah. And I was stepping into a corporate role actually for a brief period of time while specialty was independent. I was an insider of a company that was publicly traded on the New York Stock Exchange, and that was at the age of about 40 years of age, so quite young, or 30, maybe like 38 to 40 years of age, so pretty young. And then they got bought out and eventually sold to Quest, and we were just part of a big organization, and I left to join another organization called Genzyme Genetics, which had acquired another early provider of anatomic pathology testing. They had acquired Empath, and Empath had a pathology group on the East Coast and the West Coast, and they asked, could I help run the group, reporting to an executive team that was in Boston. So I had a group of pathologists in New York, there was maybe like, 16, 17 pathologists, and I had about another 12 pathologists in Los Angeles. And that was a great job. I did that for about 4 years until they were sold off, again, through no fault of ours, but the parent company went through issues with the manufacturing of a drug. They were a pharmaceutical company, and our division was a small diagnostic division. much smaller than the parent organization. And when they ran into trouble with some of the manufacturing of these genetically engineered drugs that had persistent infections in the genetically engineered cell lines, persistent viral infections in the genetically engineered cell lines, the FDA told them, well, you got to put a halt to production until you can get rid of this problem. And that was such a huge blow to the company. They ended up selling off our division in order to try to recover the stock price and fend off a hostile takeover from a French multi-conglomerate, which that didn't work. They eventually became part of Sanofi, and we became part of LabCorp, our division.
Okay. Well, Mike, talk a little bit about kind of where the joys are for you in this process. What were you finding in this experience really kind of energized you and made you exciting in the work? For a lot of pathologists, it's maybe solving the diagnostic dilemma and, name that disease kind of thing. But a lot of these, lab and business and other kind of ventures have different perks to them. So tell me where it is that your thrills come in this process.
Well, it's a great question. I mean, I think pathology is just infinitely fascinating. And if you're like me, in the OR, you were more interested in what was coming out of the patient and, sewing up the patient than you're naturally born into pathology. And I wanted to follow that specimen and figure out what was wrong, what was going on with that thing. And that organ was just immensely fascinating to me. And then as I learned more about the cellular anatomy, the differentiation of the cells and how they differed slightly, but this characteristic or this protein or this gene, it was like being a botanist aboard Charles Darwin's, Voyage of the Beagle, right? You could, or an ornithologist, you could go study all these fascinating things. It was like exploring the world. And I guess as it got further along, I became cognizant that this technology explosion that we witnessed with PCR and, gene sequencing and immunohistochemistry and fish and all these different things was opening up ways to classify diseases that had never been done before. And then, of course, there was a wave of genetically engineered therapeutic compounds that were evolving at the same time. And so I became very involved, like at Genzyme, I became very involved in selling tests that helped inform the choice of therapy. The first companion diagnostic tests like KRAS and EGFR, which were used for metastatic colon cancer and lung cancer as a way to classify whether or not they'd likely respond to a drug or not. And that was just immensely fascinating. And then I started traveling all over the country and speaking to oncologists about the use of these tests and what it would do if you were this or this at a time when they really weren't familiar with those tests very much, and they didn't know what were the sample requirements. And we had to do advisory boards to determine what would be the appropriate way to handle a biopsy from the lung or a small piece of tissue like that. It was just fascinating.
Yeah, and that's a real thrill to be able to provide answers, to provide guidance, that's going to help somebody take care of patients. And I think that's really, a lot of the joys for pathology. So how about in your day-to-day work now? I mean, tell us a little bit about you've landed in a slightly different space and so forth. So tell us a little bit about Biosept and what your day-to-day work is like now as you sort of function as the senior medical officer in this company.
Yeah, I'll give you the just a highlight from when companion diagnostics sort of exploded. This was in the late 2000s. Many companies were trying to develop these as what are called laboratory developed tests, and an explosion of sort of niche labs developed that had these niche tests for special oncology purposes. However, there was a group of pharmaceutical companies, notably Genentech, which became acquired by Roche, a big Swiss conglomerate. Roche and Genentech had felt that there should be standardization of these tests so that they would be appropriately prescribed by physicians. And they had developed a series, they were developing these IVD products, in vitro diagnostic products that would be FDA approved as companion diagnostics. And they recruited me after Genzyme was acquired by LabCorp, again, a big turnover of people and so forth. So I was recruited to go to Roche. I led a group of medical scientists and PhDs that were doing the clinical trials for Roche on a variety of products, including the first companion diagnostics that were approved by the FDA for KRAS and BRAF and EGFR. And it was a very contentious period in the history of laboratory diagnostics. The FDA and the IVD companies were saying one thing, molecular pathologists were saying another thing, saying, look, these are tests that we can run in our laboratories. We're the experts, we can run them. We don't need, you telling us exactly which tests we have to have and all this stuff. And I was caught in the middle. I was the only pathologist working at the time for Roche Molecular Diagnostics. And I argued that we should be more focused on what pathologists were saying while perhaps considering a variety of introductions of tests that weren't along the typical IVD pathway through the FDA, because that particular pathway is extremely expensive. And this is right about the beginning of gene sequencing. And I told that position that I took was very unpopular. Roche was an IVD only company at the time. And later, as next generation sequencing took off, about 3 years later, they ended up buying the largest provider of that testing, which was Foundation Medicine, in a deal worth billions of dollars again, because they were late to the party and they had failed to acquire Illumina, another company that had developed the first or one of the major gene sequencing platforms. And I left and ended up in a very small company, a company called Biotech down in San Diego, helping launch a very tailored test for a specific purpose using a very specific technology called gene expression, a gene expression assay, comparing different gene expression profiles of tumors of different type. And that was an interesting job. I loved that job, but it was not a test that was easily reimbursed. And so despite talking to payers all over the country and so forth, the company was really struggling to launch this test. And I ended up getting recruited back to Quest, which had purchased Specialty, said, would you like to run Specialty and help us with all of our esoteric testing at Quest? And I did that. I ended up leaving. And that led to a great period of working with a big company that had a lot of different labs all across the country doing really good stuff on a large scale. But I always kind of liked that smaller company focus. And a couple of years later, another small company approached me and said, would you like to be the senior vice president and, chief, basically like grooming me to be the chief medical officer for a company that was going to launch a new colon cancer screening test? And I said, that sounded really interesting. So I went to Madison, Wisconsin to join Exact Sciences just at the time they were launching the commercial launch of Cologuard, the little box you see on TV with the little figure that sits, you take it into your restroom. And we launched that test. We did all the medical education efforts, helped translate what was a big clinical trial into the, try to sort of interpret that for a general practice audience who's not necessarily reading the New England Journal of Medicine every day and doesn't know the fine points of a screening test and versus a colonoscopy. So I did that for, most of the next year, and lo and behold, again, a big, huge stumbling block came in the way of my career at something called the U.S. Preventive Services Task Force. And they had issued a draft guidance that said this test is not going to be a recommended test. And the company's fortunes plunged, and they ended up laying off people and paring back what they were doing on their development pipeline and just struggling to survive. And they kept the older pathologist who was already CMO and let go of me. Well, so such it is. I had to reinvent my career again. And I started working with other small companies, some as a consultant. I even read GI biopsies for a while, just as a routine. I read them for a guy that had started a small lab, and he had a contract doing GI biopsies for a large gastroenterology group in Pasadena. And along the way, I got recruited to help another company with another colon cancer test that was looking at colon cancer monitoring using circulating tumor DNA. They also struggled, but it gave me a lot of insight into the whole field of circulating tumor DNA. And I had worked as a consultant to another company working with circulating tumor cells. And the combination of that experience was enough to convince another company that I work for now, Biosept, the CEO rather, had called me one day last year, and he said, Mike, we really need a new chief medical officer to help us drive this test or drive this company. And I said, well, sure, Mike, that sounds interesting. His name is Mike too, Mike Knoll. I said, that sounds very interesting. And so I came into a company that had been doing circulating tumor cell assays on blood for a variety of tumors for the past, dozen years or more, and had really struggled with the changing dynamics of the marketplace and different technologies and so forth. They had struggled to stay on the forefront because they were being eclipsed by these companies that had been venture capital backed and raised billions of dollars. Whereas we were a publicly traded small cap company that had really a hard time because in the small cap world, there's a lot of what they call retail investors that just invest like up and down, they buy and sell. They don't hold it for a long time. And there are rules for small companies in terms of how much money you can raise without reporting requirements. So he was really in a quandary about what to do with the company. And I said, Mike, what we should do is focus on this one test that really shows a lot of promise, which is take the circulating tumor cell technology and apply it to the cerebral spinal fluid and find the tumor cells that are floating around in the CSF of patients who have brain metastases. This test nobody else is doing. And so starting about October last year, we launched this effort to the test was already they had already developed the test. They just hadn't really commercialized it in this. They hadn't focused the company on that, just that one test. And I said, this is where our future is. Let's go there. And so we launched a campaign to really brand this test. We just announced recently the name of the test is going to be called See Inside. Capital C, capital N, capital S, lowercase IDE, See Inside. It was just scribbled on my chalkboard one day in my office. That's how we came up with the name, along with some other similar names. And I helped recruit people that knew something about marketing and development of novel diagnostic tests, and helped work closely with a woman. So a guy I brought in named Tim Schofield has been working with a number of companies, and I worked with him in San Diego before. And then a woman who's on our clinical trial, running our clinical trials, Barbara Blau, who's from the Netherlands, and she's very smart, had worked with some pharma companies. And together we put together a small team, plus some people that run our laboratory, like Julie Mayer and others who had been involved in this development of this test. And we said, we're gonna do this. We're gonna make this our focus. And since then, I've been involved in everything from calls with investors, presentations on earnings reports. I've been giving interviews related to the technology, or talking to neuro-oncologists literally all over the country. Every week I talk to 2 or 3 neuro-oncologists, and we're developing clinical trials to establish use of this test in cerebral spinal fluid in patients with metastatic brain cancer.
So it sounds like your day has a variety of personal interactions, regulatory interactions, advertising, marketing, as well as the scientific, diagnostic, interpretive, medical consulting side of things as well. Is that fair to say? Everything,
including you're right, the strategic marketing, determining how to build a market, including physician education, clinical trials, everything. And really working with KOLs a lot, all these oncologists around the country, very important. And some pathologists, I've spoken to some neuropathologists as well, but mostly it's neuro-oncologists, radiation oncologists, thoracic oncologists, and breast oncologists. And in addition, you mentioned the regulatory sphere. We are working closely on a plan to submit this test to the FDA. So I work very closely on some of the issues that concern the FDA and CM and Medicare, because they have a pathway in the FDA for breakthrough devices that if you get a breakthrough device designation and you submit for a class 2 device, class 2 meaning it can be used for just calling whether or not tumor is there or not. You don't necessarily indicate what type of treatment will be used. That's considered higher risk, a class 3 device. So a class 2 device, you tell them whether or not there's tumor there. That can get us into a situation where we then, once we submit, if we get that designation, that clearance for the FDA, then we could get coverage by Medicare in a program called the Medicare Coverage for Innovative Technology. And that would guarantee payment for 4 years while we establish further clinical trials to really cement its use in clinical practice, and of course NCCN guidelines and things like that. So we're working toward those goals: a breakthrough device designation, class 2 FDA designation and our clearance, and also NCCN guidelines. Those are our key objectives.
This is fascinating, because I don't think anybody else has a career path like yours, and probably if you started out now, you couldn't follow one similar. You didn't know where this puck was going. but each of the things you've done has contributed to kind of the skill sets that you're using now, and that must be really, really rewarding to think back, even as far as the fish testing and other sorts of things that you were doing early, the pediatric I mean, all of these things have contributed to how you're able to use that background now in a very unique setting.
We're really doing some amazing thing. I'll show you just as a virtual background. I'll show you one of the cells where we've now. Oops, can you see it?
Yeah, you can see the red dots.
Yeah, those are HER2. That's a HER2 probe, which is the red, versus the chromosome 17 probe, or the little green dots. And the green around the cell is the halo of cytokeratin, and the blue is the DAPI within the nucleus. So you can see a HER2 positive cell, very clearly amplified HER2 gene amplification. That's a cell within the cerebral spinal fluid that is so clearly abnormal. And these patients, really, we can help them a lot. Typically, patients with a presentation like this might have 2 or 3 months to live without treatment. But with this type of treatment directed to HER2 positive gene alteration, they could live for well over a year. In fact, some patients have lived for 3 or 4 years with treatment appropriately. So it's really, really important to identify these cells. And we think this is why, pathology is still just one of the most relevant fields you could go into in medicine. It's so exciting to be part of this.
So if you were advising, one of our third or second year medical students, maybe who has a background in, bioengineering or biochemistry or, molecular genetics or something like that, what do you think, where would you start over today if you were heading, knowing what you know about yourself, where would you lean towards training? Would you still train in pathology? Would you do a PhD? Would you do basic research? What would be your launch towards where
you can pursue a lot of paths. Louis, you can pursue any path. I think the key things that lead to success are curiosity and being able to put together project plans and execute on them. So a really important thing to learn at an early age, which probably is lacking in our modern education, is we don't do enough to really learn about how to put a plan together, whether that's a business plan or a clinical trial plan. What are your milestones? What are going to be your associated costs? What are going to be your associated objectives? What's the sequence of the objectives? You have to do this to get to this, to get to this. If you can acquire those skills early, you can be really, really successful in whatever career you choose. If you just leave it up to other people to kind of tell you what to do, or you just get employed and you say, I'm just going to do what they tell me to do, you're destined to be a underachieving pathologist or physician. I'm sorry to say that, but I mean, you can be wildly successful. I could have been much more wildly successful had I really done that early. I think I would have been 10 times more successful, but I think I was a slow learner of some of the things that were really important to build experience in at a young age. I was so engrossed in my studies and my interests that I didn't learn much about clinical trials. I didn't learn much about business plans and project plans and, project management at a young age, where it really would have helped me later.
Yeah, and I think some of the training programs now have more management training and some of those kind of skills built in, informatics and things of that sort. But you're right, it's difficult to balance those with the science and the diagnostic day-to-day, because quite frankly, a lot of the people who are in the training programs don't always have all of those skills themselves. So it's it's stretching their envelope to go into teaching those kinds of skills, or to find somebody else outside the program who you can bring in for those kinds of balance.
There's a lot of ways you can get involved to get that. Like, I've heard of people that were medical students or trainees in residency who became involved in like a capital expenditure committee to help the hospital decide what equipment to buy for a laboratory, or maybe they're involved in a planning for a laboratory move or a hospital relocation where there's a lot of people involved. You can get involved in something like that. If you can get involved in something like that early, you'll learn some of these things. And I would say, don't be afraid to do things outside of your box of comfort, because the more you stretch yourself, the more you learn. And then you actually become more valuable. People will recognize that you did that, and they'll ask you to do other things that are really beyond the ordinary. Quickly, they'll ask you those things.
Yeah, that's great advice. talk a little bit about the networking. You mentioned earlier your experiences in our national organization, but balance that with your experiences in other, industry organizations and so forth. Where's the value that you see in networking outside of your local institution or practice or even your own discipline necessarily?
It's been really very rewarding to work with CAP, the College of American Pathologists, and I got involved kind of maybe like 12 years ago or more, sort of more than that, actually, probably more like 15 years ago, just speaking to them when they came to visit LA. There was a group of, I think, members of the foundation board or something visiting here, and I gave a brief talk to them when I was at Specialty Laboratories and met some of them. But later got involved going to the House of Delegates as a representative from California when I, was at Genzyme, and that was very interesting because we were of course trying to cater to pathologists' needs that they couldn't, for tests that they couldn't get in a hospital setting. We were a reference laboratory. And so I met pathologists all over the country through the organization. I got to know them really well, and going every twice a year to some of these meetings, or even more frequently if you get on a committee. I had really good colleagues from all over the country. And it was even more rewarding to get to travel with some of the companies I worked for to visit the different institutions and often call on the pathologists I had met at the national meetings and say, oh, this is where you work. And so, that cemented the relationship. They knew me, I knew them. We would be involved in some really, really interesting discussions. I sat for 6 years on the Economic Affairs Committee. I've been on the CAP Foundation Development Committee. I've been on the archives as a subsection editor. I've been more recently on the House of Delegates Steering Committee. And these are roles that just increasingly bring you into the very upper echelons of the organization in terms of what are we doing to grow the profession of pathology? How are we grooming a next generation to really meet the needs we have? And in all of healthcare, and how do we address new technologies? And how do we address reimbursement challenges? And how do we influence legislators? So we go every year to Capitol Hill, at least until the pandemic, to meet with senators and congressional leaders. And it's been really, really rewarding to do that. I'd say it's been one of the greatest things that you could do as part of a professional organization is to really get involved.
Well, that's great. Well, I think our listeners really are going to be stimulated by some of the things you've been telling them and the path you've followed. We'll sort of wrap up the formal part of this. Do you have any sort of final comments you'd like to say, final advice if you're speaking to your grandson or your great nephew or whatever sitting in the classroom in medical school? What would you tell them?
Your career is just your career is what you make it, and don't be afraid to take a giant leap forward and do something that you really is outside of your comfort zone. And you don't have to do it all at once. You can take little steps out into things that are different, and you can build on that experience. But the more experience you build early, the more valuable you'll find you become.
Well, Michael, thanks so much for your time and for talking with our audience today. I'm sure that they'll have some interesting feedback and comments to share with us, and I'll try to feed those back to you as they come along.